So yeah.
So, conceptual framework. I'm not going to go in detail.
No, they're welcome.
Most of the
forward 'cause they've
colleagues
got
here are
supper for the day.
experienced
Yeah.
practitioners, and you have been through a number of talks today. So, it's just a conceptual framework before I move on to the main text of the talk. So, acquired brain injury, what I will do is I'll talk interchangeably. So, acquired brain injury, traumatic brain injury, and head injury. And these are the terms that we use in medical literature. And consequences of ABI, I'm not going to go into detail of all of them, but just to list them is emotional, cognitive, neuropsychological, behavioral, neuropsychiatric disorders, and lots of social complications. And talking about early life brain injury, I think the social aspect is the most important aspect to keep in mind, is that we are not just talking about the etiology or pathology. We are also talking about children who are going through life adversity at a time when they were supposed to learn to socialize, when they were supposed to acquire a large number of occupational and social skills and learn to survive in this wide and very complex world. So the adversity not only arising from the pathology or acquired brain injury, adversity also arising from lots of other aspects of not being able to learn and not being able to then live as lots of other children are able to do that. So one of the patients I've looked after who was aspiring to become a doctor had her brain tumor at age 11, bright student, okay, now she's 15. When her friends come to see her, she practically has a relapse. She gets very distressed, she gets depressed, she can become aggressive. If you talk to her, she will tell you that she's left behind and other children have moved on. So even seeing friends from old days can become a major stressor. And just talking about it, I think it's important to keep in mind that we are talking about children. And most of the literature that I will go through very quickly will be about childhood onset conditions, but we need to keep in mind that these children do grow up. Okay? So children who were described as having a shaken baby syndrome many years ago, now you see them in your clinics as an adult, for example. Children who were diagnosed as suffering from autistic spectrum disorder in childhood or ADHD, now you see them in your clinic because they are also accident prone. They have developed a traumatic head injury on top of. Okay, if they are unlucky, you will see them when they are in a wheelchair. And you can imagine a child, now a grown-up adult with ADHD in a wheelchair, and how difficult a life prospect may be for that person. So just complicating a picture a little bit. When we talk about early onset brain injuries, and it's just a conceptual framework, and some colleagues may think differently, but from an academic viewpoint, you have to have a conceptual framework in order to describe a particular policy issue or a particular phenomenon. So we are talking about injuries occurring before age 16, and then a division between people who then can be classified as having a learning disability based on early onset and low IQ. Of course, you need to keep in mind that a large number of children, after their traumatic brain injury or acquired brain injury, their IQ is not affected much. Okay? And they survive, and they are the ones who fall through the nets, because when you go to pediatric learning disability service, they say, oh, their IQ is a bit high than what we take. You go to adult services later on, and then they just go through the circles. Okay, so from a service perspective, in early years, most patients are seen by pediatric services. There are very few child neurodisability services or child neuropsychiatry services. Just to keep in mind, I'm repeating the point that a significant proportion presents with behavioral learning and social difficulties in the absence of low IQ. And of course, some patients are looked after by child psychiatry services. Okay, Now, having said that, just keep in mind that clinical life is not simple. When I'm saying clinical life is not simple, is that a lot of people have multiple problems. Okay, they come from a particular family background, or they have a comorbid illness, or they are prone or at risk of developing particular social or physical health consequences. So, for example, people with ADHD may be accident prone. I gave an example earlier, and they can be at risk of traumatic brain injuries. They are at more at risk of developing burns injuries if you look at longitudinal population-based data. And people with traumatic brain injury are at higher risk of seizure disorders, and seizure disorders can bring in more complication. They can bring in complication, especially for younger children. And if they develop treatment complications, or if they go on into prolonged seizures, then that adds to their difficulty. Then we know that physical treatment of manifestations of some genetic disorder may result in traumatic brain injury, like management of tuberous sclerosis. And then some conditions with what we call is unknown etiology, cerebral palsy, for example. We know there is an association in some cases, at least, with newborn jaundice. So children with cognitive damage, if you look at the literature, may be at a higher risk of physical abuse. Okay, so if you look at the case studies of babies who have been described as now suffering from shaken baby syndrome, a significant proportion had pre-shaken baby phenomenon cognitive issues, and that creates another cycle of policy debate, is that are there any preventative measures that can be put in place in order to support these children. Intracranial infections and autoimmune encephalitis may present with a recurring pattern. So we have now looked after children who are going through their second or third bout of autoimmune encephalitis, and that creates a problem for family, for the children, for their schooling. And of course, if you give them the right treatment and liaise well with the pediatric neurology departments, then they get better and they go back, but they remain at a risk of developing another bout later on in their lives. And of course, we know that brain injuries increase the risk of having another brain injury in later life. So it's a cumulative risk. Okay, so understanding brain injury in early life, important. What I'll do is I'll very quickly go through outcome of head injury in children, some literature, briefly talk about, again, epilepsy after head trauma, non-accidental injury in children, head injury in children with psychiatric disorders, brain tumor, and then I'll briefly talk about long-term outcome of intracranial infections, and then phenomenon like war, famine, and radiation exposure, just taking the brain injury context to the wider world. Colleagues here who are working in London or other major cosmopolitan areas, they will be kind of familiar with immigration impact and migrants coming over into this country, and they must be familiar with children presenting with low nutrition status and then developing a large number of problems. Children having gone through war trauma or other horrible impact and left with quite significant damage as a result. So there are a few good studies. If you look at the literature, then there's a particular study that I've cited here, is 159 subjects, mean age injury 7.96 years, severity of injury predicted long-term outcomes, and IQ recorded in post-acute phase predictive of long-term outcome in terms of cognitive functioning and social functioning. Then another study with inconclusive results. And then this 2-year follow-up of academic achievement, and 79% of severe TBI group had either failed a grade or received special educational assistance. And that is where the evidence for policy intervention comes. For children who can be diagnosed or described as having brain disorders of any type. I'll talk about it in a policy context later. Again, epilepsy after head trauma, there are some references. Of course, as we know, the risk of epilepsy increases after TBI. Risk remains high at 10 years. In children, especially, risk higher in females, older children, and children with family history of epilepsy. And it has to be, this risk recognition needs to be part of treatment planning. And then another sample reported epilepsy in 9% of their TBI sample. But generally, there is no conclusive evidence whether children with TBI and epilepsy and children with learning disability and epilepsy differ in behavioral presentation. They do differ, however, in educational attainment and how they function socially in their schools. Again, some references related to non-accidental injury. This is a 19-year population birth cohort. Children with disabling conditions are increased risk of registration for child abuse and neglect. And I think that's, again, a policy intervention evidence. And then if you look at studies related to shaken baby syndrome, there are many now. So just reminding that shaken baby syndrome is largely restricted to children under 3, majority under 1, and it causes diffuse axonal injury, subdural hematoma. That's a typical presentation. But now, in clinical life, these children who were described as having a shaken baby syndrome, you're seeing them as an adult. So I think the kind of the cohorts growing up and cohorts surviving. And again, going back to the brain tumor example, with advances in medical treatment, more children are surviving with better treatment. They are coming out of hospitals. Okay, they're living longer. And you are seeing more and more of them with cognitive or behavioral difficulties. Or you are seeing more of them presenting with delirium in acute confusional state at a time when they have only 6 months or a year to live, practically, and the healthcare professionals' job is to keep their life comfortable, manage their family anxiety, keep them make sure that they are able to return to live at home for a few months prior to their death. And again, that's a new area of intervention for colleagues who are working in field of brain injury or traumatic brain injury. So again, it's for interest that this is a very good study. It's a very large cohort, and it just describes that which disorders are associated with which type of injury. So oppositional defiant disorder associated with burns and poisoning, and ADHD associated with fractures. But then some association with head injury as well. But in practical life, you see a lot many people with head injury with ADHD than presenting with head injury. If you speak to experts in ADHD, then these are the patients whose treatment response is different from classical ADHD, and one can argue whether there is a condition also called post-head injury ADHD type presentation or not, but that's a different debate. Intracranial infections, so I've just whizzed through a number of topics. So children and adolescents account for about 1/3 cases of herpes simplex encephalitis, and 2/3 of survivors will have significant residual neurological deficits. Herpes simplex encephalitis is the commonest viral encephalitis, lethal in many cases, but now with early introduction, early investigations, and introduction of antiviral treatment, people are able to survive. It typically affects frontal and temporal, so that's the distribution and scarring in brain. And a typical pattern is a kind of frontal lobe or executive function deficits and memory deficits. So we are now looking after people who are 22 years past their encephalitis, still present with significant behavioral difficulties, still present with significant memory difficulties. Of course, through structured treatment planning, a good care plan around them, but can they survive without that structured care plan around them? That remains a question. now, just moving outside of the UK, we talk about cerebral malaria associated with long-term cognitive impairment. It is common in Africa, certain parts of Africa. You see patients in different Asian countries. Bacterial meningitis is known to us, and again, these figures highlight that a significant proportion is left with significant cognitive damage. And now, if you go to there is a large number of new viruses being isolated and identified. So I was just doing a literature search a couple of nights ago, and there was a new strain identified just last week, particular affliction from brain and causing encephalitis. So now, a few quick words about war, famine, radiation exposure, as I did talk earlier. So wars, typically, if you talk about one interest of mine is what we describe as blast injuries, or what we call is neuropsychiatry of war trauma. If you go in detail, then war trauma affects individuals in a differential way. So it's a different trauma for civilians, it's a different trauma for combat forces. There are no winners. You see a lot of casualties and a lot of very damaged people. For children, especially, they are prone to develop significant difficulties if there are bombings around them. Not only difficulties in terms of kind of their psychological trauma, but of course they do sustain blast injuries. And the cohorts of children who have sustained blast injuries, again, they are growing up now, and you can see a pattern of studies and a lot of difficulties they go through. But then it's not just the blast injury they go through. Blast results in destruction of property, the areas that are hit by bombs, then you see a displacement and mass migrations, and then malnutrition, and then them having to move to different parts of the world. Okay, so a lot of it comes in a package. And people who, I was mentioning earlier, in major cosmopolitan, even in European countries, they are familiar with these patients, and they talk about where to start and where to finish therapy and how many issues that require dealing with. Again, going back to Nagasaki and Hiroshima nuclear bomb cohorts, they do report cognitive deficits. So the people who were children at that time, kind of they grown up many years, and some of them are still surviving. I don't know how many now. And again, keep in mind that in children with brain tumors, and again, that is talking about radiation exposure, and that's an example from our modern hospital-based life, is that the rate of IQ decline reported to be associated with radiotherapy treatment, volume of brain that receive treatment, and cerebral white matter loss. And again, with radiotherapy, many children are surviving their brain tumors, and that we need to keep in mind. But we are seeing many damaged children at the same time. So in summary, brain injury is a complex phenomenon. It is difficult to estimate the extent of current healthcare utilization by young people with brain injury. We don't have any registers in areas. We don't know what is the at-risk population. We don't know how many people are likely to develop brain injuries of different types, based on that it's a complex cluster of etiologies that we are looking at. And a significant proportion comes in contact with neuropsychiatry and learning disability services, but at different times in their life. Treatment target setting, measuring treatment effectiveness, and discharge planning of patients with early life brain injury does require careful planning, and do throw a large number of challenges for treatment planning as well as for policy makers in the country. Thank you. Okay, so we have a few minutes. I can take some questions or comments. Please.
Thank you for a most interesting talk. Thank you for a most interesting talk. I'm John Murphy. I'm a TBI sufferer and adult general psychiatrist. What's your perspective on the whether having TBI predisposes to dementia in later life?
Right. Well, if you look at the evidence, to my knowledge, there are two systematic reviews. So systematic reviews are, as colleagues know here, are studies who compile the evidence published in a large number of studies together, and then they look at whether there is a dementia risk or not. So one systematic review does identify that yes, there is a risk of dementia in particular groups. The other systematic review that was done by Simon Fleminger does record some study, but it's not a conclusive evidence, and I think that is where the evidence lies. However, if you speak to what we call neuropathologists, so these are people, as you know, they are experts in brain pathology, and a lot of time, by the time patients reach them, they are already dead. So they are able to do post-mortem studies, and they are able to cut slices of their brain. Then neuropathologists do argue, and neuropathological studies do present data of post-head injury changes that are not exactly like changes in Alzheimer's, but closer in terms of neuropathology inside. Okay. One can argue that people with repeated traumatic brain injuries, and we did talk about a cumulative risk of head injuries after head injuries, okay? Then one can argue that those are the people who may be at a higher risk, okay? And part of the evidence may come from what is described as dementia pugilistica, or if you remember the case of famous boxer Muhammad Ali, and whether that is a risk. But there are different neuropathological cascades. Does that answer? Yeah, thank you.
I'm just keen to know the prognosis for patients who survive attempted hanging.
Yeah. Attempted hanging, thing is, where I work, we have around 105 inpatient brain injury beds. And we do our analysis from time to time. So I'm not aware of any long-term, but I think at any stage around 10% of our population is, patient population is suicide attempts. And usually significant proportion of them is attempted hanging. The question is how many people attempt to hang themselves and how many of them survive. And then how does their survival result into improvement over a period of time is a very difficult question. I can comment on general trends that we have seen in patients. So after hanging, kind of you see severe damage. Of course, brain swells up. The damage is more global because then the blood supply stops, and then there may be other impacts in relation to cervical spine fractures or other mobility difficulties. With severe global damage depend on the length of the hanging and when people discover it. Generally, you see slow recovery, and you don't see full recovery. You see people who are left with significant kind of deficits in a large number of areas. But of course, I can say that I've seen one or two people who did very well. Okay. A similar example, not exactly the same pathological cascade, may be pupils surviving from cardiopulmonary resuscitation. So these are the people who are going into prolonged cardiac arrest. And now that our CPR techniques have improved, they are readily available, our ambulance responses are quicker, and our A&E teams, despite criticism, are working much better. So many people are surviving, and that's the pattern you see is a more global pattern of damage, and then a variable pattern of recovery based on how long people stayed in the cardiac arrest or how long people stayed, going back to the hanging question, were hanging. Yeah, yes.
Thanks, Rafi. It was an interesting talk. Just wondering, where do we stand in terms of diagnosis? Say, if someone presents at age 18 with schizophrenia or personality disorder or ADHD and had sustained a head injury at the age of 4, how would we sort of go on to with the diagnosis, whether it would be an organic psychiatric illness or whether it be a functional psychiatric illness?
Well, one solution is that you give them a list of diagnoses, okay? And sometime when you're reading reports or preparing reports for mental health review tribunals, you list a large number. A highly unsatisfactory position, but that is what you have to do in certain circumstances. If you look at our classification systems, and I think the one we use here is ICD-10. If you look at the organic mental health chapter, there are a lot of areas that are not satisfactory. Mike would know we had a subgroup that looked at organic disorders classification some time ago, and we advised WHO. And the basic idea was to simplify it, make it actually pathology or etiology based. So our simple suggestion in terms of brain injury is that if people have kind of sustained some problem like cognitive or behavioral, or then basically just say the cognitive and behavioral problem associated with traumatic brain injury or acquired brain injury. So the recommendations we have made are a bit complex, but in a way that is the core suggestion. So ICD-14 is due. ICD-11 is due in 2014, and Neeraj has, I think, gone over to the other Neeraj Agrawal. We just agreed 3 weeks ago that I and Neeraj will lobby World Health Organization to make sure that the recommendations we have made are put in the classification system. So that's a piece of work we need to do. Any more questions before I conclude the session? No? Thank you very much. Thank you for patient listening.